Right, well, I'm going to press record and I shall introduce Professor Corbett. So wonderful of you to give your time on the weekend, Professor Corbett. Thank you. I'm going to introduce you as the honorary VMO in the Neurology Department at Concord Hospital. In 1986, you were appointed as the head of neurology at Concord, and you've continued in that role until 2016, and now you're doing you're still consulting at Concord, and your main interest has been in neuromuscular conditions and as well in stroke and Parkinson's disease. You established the neuromuscular clinic and rehabilitation team with the clinical geneticists there, in close liaison with cardiology and respiratory at Concord, and you continue to do clinical research in the inherited and acquired neuromuscular conditions, and you're a former director of MD New South Wales and a good friend as well. So thank you for your time today, Professor Corbett. I'm going to pass it over to you, and you might just like to run by how you'd like to take questions as well. I think you're happy for people to ask them as we go.
Right, what I'm going to do is share my screen, and we're going to go through a few slides. I'm happy to take questions as we go, or if people want to send questions by chat, whichever suits. So we'll see how we go. A lot of this is going to be fairly technical, but I wanted to really give you a flavour of where FSH is at the present time. Unfortunately, it is one of the more technically difficult of the muscular dystrophies, so let's get started. Good. So it's really the third most common of the muscular dystrophies after Duchenne and myotonic dystrophy, and in later adult life it's the second most common. And its onset can be at any point through life, from congenital disease, which fortunately is quite rare, through to very late life. And there's a wide range of severity. And the males tend to be more affected than the females and to have an earlier onset. So we think that estrogens probably have somewhat of a protective effect. Now, again, it differs from most other muscular dystrophies in that it's asymmetrical and stepwise. This means that it's difficult to predict what's going to happen next. The places that are most involved are the face, the shoulder with winging of the scapula, wasting of the arm, weakness of ankle dorsiflexion resulting in foot drop, weakness of the abdominal muscles so that people, even if they don't carry any extra weight, have a bulging abdomen, and weakness of the paraspinal muscles, which mean people have a weak and often painful back. Often the first thing that people are aware of is actually sleeping with the eyes open and developing dry eyes. From there, it's difficulty raising arms above the head. Because of weakness of the ankle, people roll their ankle when they're on an uneven surface and trip. They have increased spinal curvature, bulging abdomen, develop a waddling gait due to the lower back weakness. They also have an unusual increase in retinal vascular permeability, and this can lead to retinal detachment, which is usually associated with more severe disease, but it can lead to loss of vision, and it's something that can be corrected if you know when you have sudden onset of loss of vision, getting into the emergency department, getting the retina reattached, terribly important. In contrast to Duchenne and myotonic dystrophy, bulbar musculature, that's muscles of the throat, muscles that are involved in swallowing and speaking, very little if at all affected. Breathing muscles are not affected until very late in the disease. Cardiac involvement, of course, the heart's and other muscles, relatively rare, and most patients, other than early onset children, have normal life expectancy. However, there are significant physical limitations, and this often results in disability, need for job modifications, risk of wheelchair use, although most patients get through life without one. And there's marked clinical variability between and within families, with even some people having the gene with very little to show for it, what we call incomplete penetrance. As we've said, the bulbar respiratory and cardiac involvement is relatively uncommon, so these are the facets of most muscular dystrophy we spend most of our time managing. Now, FSHD does respond well to exercise, but this needs to be low intensity aerobic exercise, avoiding pain or injury, and this does help people retain strength, and we now have trials to show that the people who exercise regularly do much better than the people who don't. Control of pain is a real issue for FSHD, not so much in other muscular dystrophies. We use non-steroidal anti-inflammatories like Nurofen or Mobic to cope with pain. Often we use antidepressants, which also have pain relief properties, or anti-epileptics for chronic musculoskeletal pain. And the sort of medications that we use on the antidepressant side is duloxetine, which has pain relief effects. On the anti-epileptics, particularly gabapentin and Lyrica. Orthotics have a role to play. They often assist with ankle stability. Scapular fixation's been used. It's more a cosmetic procedure than one that actually improves shoulder function. And heart monitoring we use occasionally. I do have patients with FSHD who have cardiac arrhythmias, irregularity of the heart. I've mentioned the exudative retinopathy that can lead to retinal detachment and loss of vision. This is a potentially preventable in patients with large deletions of the gene, and we're going to come to the gene in a minute. They should be screened by an ophthalmologist. We can actually see the abnormal vessels before the problem occurs. Because of dry eyes, a lot of patients need eye lubrication. Hearing loss is reasonably common with FSH, and this is important in young children where it can interfere with language development. In later life, we can use hearing aids and other means. We can avoid passing the gene on if we know that it's there using pre-implantation genetic diagnosis. This is an in vitro fertilization technique where egg from the mother and sperm from the father are taken, put together in an in vitro fertilization manner. Then when the developing embryo has about 8 cells, one of those cells can be taken and it can be tested to see if each embryo carries FSHD or doesn't. Whether you use PGD or not is very much a choice of the individual couple. It's made in conjunction with a neurologist and with their geneticist. Exercise is important. We've talked about orthotics and pain relief. Now, genetics for FSHD is complex, and it was one of the latter disorders to be described. It's caused by reduction of size in a DNA fragment at the telomere. Telomere is the technical name for the end of chromosome 4. So it's the Q telomere of chromosome 4, what we call 4q35. Reduced fragment size is due to a deletion of repeated units of a DNA repeat sequence called D4Z4. D4Z4 contains the gene for a double homeobox protein 4 called DUX4, and you're going to hear these terms D4Z4 and DUX4. D4Z4 is the DNA repeat sequence that's shortened. DUX4 is the individual components of that repeat. Each repeat represents a unit of DUX4. So FSHD also requires a special structure at the end of chromosome 4. This is called the A haplotype, and this includes a polyadenylation signal, and this allows DNA to be transcribed into messenger RNA. If you don't have the A haplotype, even if you've got a reduced length D4Z4, you will not have FSHD. So FSHD doesn't occur on other haplotypes, even with that contraction. So we need that A haplotype. And up until relatively recently, we had great difficulty haplotyping the 4 chromosome, the 4q end of the chromosome. And that's something that we introduced to the lab about 4 years ago. This is showing diagrammatically. We have the normal situation at the bottom here where there's between 11 and 100 repeats of DUX4 making up the D4Z4 repeat structure, less than 11 repeats, and we have facioscapulohumeral muscular dystrophy. So FSHD1 requires at least 1 and fewer than 11 D4Z4 repeats. The general population has greater than 11. About 20% of our patients are new mutations. The other 80% inherit this disorder from their parents. Now, when we have 11 or more repeats, it means that the D4Z4 repeats become methylated, and when DNA is methylated, it can't be turned into messenger RNA, which in turn is turned into protein. So with this, we have a toxic gain of function, a deleterious process whereby the DUX4 protein is formed because the D4Z4 has become unmethylated, and the first of the repeats, the first DUX4, is translated into protein. Now, more recently, we've found that we have FSHD2, and there's probably also FSHD3 out there. So with FSHD2, there's a normal number of D4Z4 repeats, but DNA is not methylated. So production of DUX4 mRNA, which is translated to DUX4 protein, occurs, and this is generally more severe than FSHD1. FSHD2 can't be detected by standard FSHD testing. We need to look at the gene that results in this lack of methylation, which is called SMCHD1 or SMUDGE1. So DUX4 protein is the toxic species, and this stimulates a cell process called apoptosis. Now, it's only produced in very small amounts, and it's produced only from time to time. The apoptosis is the pathway of irreversible cell death. So a lot of cell death occurs by the process of apoptosis. In the fetus, DUX4 is active and it limits muscle growth, but it's suppressed in the adult because in the adult, we want to encourage muscle, we don't want to trim it. In the fetus, there's overproduction of a lot of tissues, including muscle, and they need to be trimmed back. So DUX4 has a role to play in the fetus, but following birth, it's suppressed. Now, DUX4 is interesting because it's produced in birth.
We were really interested here, and anything that's greater than 3 is considered a significant clinical improvement, so something that we would really notice if we were examining people. And so you can see that over time, the benefit continued to improve. So at 6 months, 28% of people had a 3-point improvement or more. That rose to 35% at 10 months. And then when we got out to 14 months, 40% of people had had at least a 3-point improvement on that motor score. This slide shows the number of patients who showed improvements in their 6-minute walk test over time. And so along the bottom here, we see bars that are representative of each individual in the study. So at 6 months, the data are representative of 47 participants. And along the side here, we've got the change from that way they started at. So if you went up, it meant you could walk more meters, and if it went down, it meant you were walking less.
With an acute inflammation and weakness in his heart muscle. and that included a range of medications, and he actually did very well, and his chest pain resolved. We were able to undertake an MRI scan in him, and I'm sorry that you can't see the mouse, but it's the heart muscle's right in the middle, and there's a little raft of brighter tissue, and that's exactly the finding that you see.
To make any access accommodations for parents with disabilities only to students. So if a student was in a wheelchair, they'd be required to make a hall, a toilet, classroom accessible, but not for a parent. Which is worth knowing if you want to attend any events at the school or go into the classroom to speak to the teacher. On one parent-teacher night, my son's teacher changed the location on the day from a ground floor library to an upstairs classroom. And luckily in class, my son put up his hand and said to the teacher, "My mum can't go upstairs." And, of course, then there was a frantic phone call to me to make an alternative place to meet. But had he not said that, the teacher would have been waiting upstairs and I would have been on the ground floor wondering where classroom 6B was. We actually go to an out-of-area school because the catchment schools are up a steep hill. Couldn't get in and see what she was doing anyway. When it comes to support workers, we've had more downs than ups, and it gets a bit confusing.
For FSHD, one in collaboration with Professor Chad Heatwell in Rochester, New York, where we've adapted his outcome measure, the FSHD Health Index, to be used in Australian patients, made certain that it was relevant and appropriate to the Australian community. And the other one, which we're just in the process of publishing with a Dutch group, to allow us to potentially participate in Dutch studies, again using a European FSHD patient-reported outcome. And I think this is going to be more and more used. Again, with a patient-reported outcome, we're looking at the things that are important to patients. What do they want improvements in? What are their greatest problems? And it allows us to look at a whole range of things. Now, another thing that's being used at the present time in the early trials is to actually take muscle from patients and to look for DUX4 gene transcripts. DUX4 itself, the protein, is made in such small amounts that we really can't measure it, but we can measure the gene transcripts for DUX4. Now, what potential genetic strategies do we have? We could suppress DUX4 production, and antisense oligonucleotides would be a potential way of doing that. Antisense oligonucleotides are being used in Duchenne dystrophy to enable exon skipping. They are starting to be used in myotonic dystrophy to break down the repeat sequences, and they could potentially be used to suppress the production of DUX4. Where the real interest at the present time is in blocking the activity of the DUX4 protein. And there is now a trial of an agent called losmapimod. This is a selective inhibitor of an enzyme called MAPK, or P38 mitogen activated protein kinase. And this results in a potent dose-dependent reduction in DUX4 activity, and this presents cell death in patient-derived myoblasts. And there's now a trial underway, and 80 patients are being randomized at the present time to receive either losmapimod or placebo and to be treated for 29 weeks. This will really only be a trial, a pilot study. It won't be the trial that will introduce this finally to the larger patient community. But this is currently underway in the US and Holland in particular, and we don't have any results yet. Now, the nice thing about losmapimod is that it's actually been trialled in a number of other human conditions. MAPK is an important important producer of inflammation. So in disorders in which inflammation becomes a major issue, suppressing MAPK could potentially be very helpful. And this has been looked at in respiratory diseases, heart diseases. Unfortunately, it didn't work. Fortunately, it doesn't have much toxicity, so it seems a very safe drug. So we're hoping that in FSHD we've found somewhere where it's not only going to be very safe, but it's also going to be effective. So I think this is a real hope for the future. Now, there are other medications being looked at the present time, but they're all in an earlier stage of trialling. We don't have an effective genetic therapy yet for FSHD, one that's reached the trialling phase, but Michelle Farrow, when she was talking, mentioned CRISPR, the gene editing technique, and that's certainly being thought about for FSHD. But again, just to stress, one of the problems with FSHD is that we don't have the animal model that we can trial it in at this point in time, which would make it a lot easier to develop tools like CRISPR for treating FSHD. So I think we've got an exciting future, and I really do think we're going to see some action and some treatment in the near future. Now, what can we do? We'd hope to have an FSHD registry available for you. We actually developed one a number of years ago, it'll be 3 or 4 years ago, in conjunction with the West Australian Health Department, and the database is written. It's all in a state where it was ready to go, but West Australia had a number of other problems and they dropped it. It's now been rehoused at Monash, and it's pretty much ready to go. We don't have the ethical approval to register people locally, but I can give people information that would allow them to approach the team in Melbourne and actually register on the database. We have a lot of trouble with getting ethics for using databases based around data security. I think these things are very secure, but this is a currently still a significant issue. I'll stop talking at this point, and I'm more than happy to take any questions about FSHD.
Thank you so much, Professor Corbett. There was a lot of information there, and
there is a lot of information. Yeah. I apologise, but it's an exciting area. We clinicians get a bit carried away at times.
Yeah, no, that's completely fine.
I'll just try and unshare my screen.
Yeah, good idea. And it's better to have that more information that people can unpack and work over rather than not having the information. So we appreciate that thoroughness. Is there any questions that people have that? Firstly, let's stick with questions about FSHD, because I know there are other people in the room that are interested in other conditions, and we might do FSHD first. Is there any questions from people about FSHD or about what Professor was talking about?
I'm happy to answer other questions as well.
Yeah, great. Rob, we might go with you first.
Oh, thanks. I'll just confirm, Professor, that you said that fluoxetine antidepressant also has some anti-pain effect?
Not so much fluoxetine as duloxetine.
I see, thank you.
Yeah, there are several that have specific pain relief effects. So, some of them have more than others, but we're using those medications more than we were in the past, possibly primarily for their pain relief properties rather than anxiety and depression. But they're effective for both, and people who are in a lot of pain, often both issues, the anxiety, depression is an issue as well as the pain.
Thank you.
Tom, did you want to ask your question now?
Yes. Hi, Alastair.
Hello.
I've got limb-girdle muscular dystrophy. I wasn't aware there were so many similarities between the two. The repeat sequence thing was kind of interesting to me, and that's sort of mentioned in line with the telomeres. And are they linked at all? The telomeres and the winding at the end of the genes are sort of to do with.
Telomeres are an interesting part of the gene, and one of the reasons it was very hard to find the genetic defect in FSHD is it's actually very hard to look at that very far end of the gene, the telomere. No, it's not specifically got anything to do with muscular dystrophy. It's just chance that FSHD is right on the telomere of 4q. But telomeres are a lot of interest. There's a lot of interest in telomeres, and we think that a lot of problems that occur as we age are because of degeneration of our telomeres. So no, you're going to hear more about the telomere or the tail of the chromosome as time goes on, but it's just sheer chance that FSHD is sitting right there on the telomere.
Okay, and I was just going to ask also, with limb-girdle seems to have a more predictable progression.
It does, yes.
Types, and are there any the trials for LG muscular dystrophy more predictable, or maybe are there trials going on in that area?
Yeah, look, there's a lot of thought in the limb-girdle muscular dystrophies. Each of them is individual depending on the genetic cause for it, and each of them would require its own specific treatment. This is one of the difficulties of muscular dystrophy, is that no, there's not a general principle behind them. Almost every disorder has some different genetic principle that controls it. So things that are developed for Duchenne are difficult to translate into other muscular dystrophies, similarly with FSH. So a lot depends on which of the limb-girdle dystrophies we're dealing with. Again, a lot of them are significantly less common. There are 3 or 4 relatively common limb-girdle dystrophies, but then there are a lot of very uncommon ones, and there are still many that we haven't yet identified. So it's a big area and a lot of work to do. Now, as time goes on, as Michelle said, and we get used to using genetic therapies, we're going to be able to generalize more. We're going to be able to develop principles better, and we may well be able to treat disorders with relatively little trialing and relatively little run-in as we sort of get our heads around how these genetic therapies work, what's safe and what isn't. I think it's going to become much easier to develop new treatments and to know whether they're going to be effective, and the trialing process will probably become truncated. At this point, it's long, it takes a lot of time. We have to be very careful that what we're doing is safe, but I think there will be general principles that come out of the trials that are being done at the moment that will allow us to fast track a lot of things. So I think we'll go from a point where very few things are happening till we get an avalanche. Now, we hope we can get the research funding to do all this. We're excited about the adeno-associated virus lab being developed in Sydney, and my colleagues already have some proposals to treat disorders that they hope that they can use this for in the near future. So we may be well able to develop things. The investigators here in Australia may well be able to develop treatments for the first in class.
That's very promising. That's great. Any other questions for Professor Corbett about FSHD or other conditions that he may know about? Nina.
Hi, Professor Corbett. I was just wondering what the ethics are about using the animals for trials.
Yes, look, it's always a difficult one, and no, the situation is that there are very stringent protections around using animals. No, there are animal ethics committees that are set up to make certain that animals are dealt with as humanely and ethically as we can. At the end of the day, however, we cannot go directly from cells to humans. We would lose a lot of people along the way, and our ethics of doing that are considerably muddier. No, even as things stand at the moment, going from animals to humans, there's always a significant risk. Generally, things are developed in mice, and those mice obviously wouldn't exist if they weren't there for the trial, but at some point there's often a need to do some very limited trialing in primates as well, because primates, again, are much closer to humans, and we're much likely to see toxic effects. But this is kept to an absolute minimum. Our ethics committees make certain that these things are as controlled as can be.
So what do you mean by primates? Do you mean monkeys?
Primates means monkeys, yes.
Right.
So that's the final stage before it goes to humans. But as we become more confident that our treatments are not deleterious, we can bypass a lot of this. So we start with individual cells, usually cultured from people with the disease. We then try and put the gene into an animal, so the animal expresses the human gene as part of their makeup. See that the treatment's effective under these circumstances. We then may have to check and see if what we're using, if it's completely new, is tolerable in a primate.
Okay, thank you very much.
Okay.
Any other questions, guys? Wow. That's how thorough you were, Professor Corbett. All right, well, I think that I would love to take a photo if everyone doesn't mind. If you do mind, please hide your camera, but we'd love to see your face. It's lovely to have a record. It's I love a family photo, so let's do that, and then we'll break for... Ganesh, would you kindly take a screenshot for us at all? You're good on the tech. Ganesh is our resident photographer at the office. Not that we've been in the office all year, but yeah. So 1, 2, 3. How's that, Ganesh? One more. The only time we're quiet, isn't it? Got it?
Got it.
Excellent. Thanks, Ganesh. We really appreciate it. Alastair Corbett, thank you so much, Professor, for your time today and all that great expertise of wealth of knowledge that you've got over those years of practice. Thank you for sharing with us. Yes, let's give Professor Corbett a little round of applause. I can do a little clap on mine as well. Thank you for that, Tom. Yeah. Oh, look at that.
Thanks very much. It was a real pleasure. I enjoyed it.
Yeah, we're really grateful to have your support, and you never know, we might see you next year online. We might be back in face to face. Who will know that?
Let's keep our fingers crossed.
Yeah, it looks, there's
I'm certainly
pros and
hoping.
cons, isn't there? There's pros and cons. We love a face to face, but this format is offered, people who may not.
Look, it really does have its compensations.
Yeah,
yes.
does.
So I think we've got more people here than we'd normally expect.
Yeah, we do. So that's really great. Yeah, I think all the other sessions are very full as well. So thank you very much, guys, for your time.
Good.
And thank you, Professor. We're going to head back to the main session at 5 to 4, and then I'll be able to introduce... Oh, Nina's in Brisbane. Thank you, Nina, for joining us. Excellent. Yeah, you would not be able to travel from Brisbane. So we're going to join back at 5 to 4. So everyone go and put the kettle on, and thank you very, very much for your time today.
Good. Thank you.
Lovely to
Good.
see you. Bye-bye.
Bye.
Bye. Thanks, Ganesh. All right, I'm going to go and get a drink myself because I haven't done that yet. So I'll go and put my camera on. Here we go.